Welcome to the weekly Neurology Deep Dive.
Glad to be here.
Just a reminder for everyone listening, this program is strictly for educational purposes. There are no commercial goals here at all.
That's right. It's a summary of some recent research.
And we really do recommend you read the full published paper to get the complete context and all the fine details.
Definitely essential.
So today we're taking a deep dive into a recent systematic review and meta-analysis. This one explores the link between lipoprotein A levels and outcomes after an ischemic stroke or a transient ischemic attack has already happened.
Right, the secondary prevention context.
Exactly. Our deep dive is based on the paper, The Association of Lipoprotein A and Stroke Recurrence, a systematic review and meta-analysis from the Journal of Stroke 2025.
A very relevant publication.
Our mission really is to unpack what the study found. We want to pull out the key data, the numbers, and the practical insights that matter for your daily clinical practice in neurology.
It's certainly a hot topic. Lipoprotein A keeps coming up.
It really does.
Yeah.
And understanding its role after a stroke feels incredibly timely.
It does. Lipoprotein A, it's been recognized as let's say, a significant cardiovascular risk factor for a while now.
Right, for primary prevention.
Exactly.
Yep.
But its specific role in secondary stroke prevention, preventing that second event, that's been, less clear.
So clarifying this could really impact how we manage these patients.
It certainly could influence how we assess risk and, maybe even treat our stroke survivors down the line.
Okay, let's dive into the source material then. Starting with the basics. What is lipoprotein A, according to the paper?
Okay, so the paper describes it as a lipoprotein, structurally quite similar to LDL cholesterol low-density lipoprotein.
The bad cholesterol people talk about.
Sort of, yes.
Yeah.
But the key difference is this extra protein attached, called apolipoprotein A. That's unique to lipoprotein A.
And the paper notes it's largely genetic, right? Unlike LDL, which lifestyle impacts more.
That's a crucial point. It's primarily considered a genetically determined risk factor. So diet and standard statins don't lower it much, if at all.
The source also mentions why it might be bad, the mechanisms.
Right. The thinking, based on the paper, is that it has sort of a double whammy effect. It seems to be prothrombotic, promoting clots, and atherogenic, contributing to plaque buildup.
So it could make plaques unstable, help clots form, increase inflammation.
Precisely. All things you don't want happening in blood vessels, especially cerebral ones.
And we already knew there was some link to a first ischemic stroke, particularly in maybe younger people or those without the usual risk factors.
Yes, that link for a first stroke is fairly established. But the real question this study tackled, the gap they mentioned, was its role in secondary prevention. Does it increase the risk of another stroke?
Which brings us nicely to the study itself. What kind of study was this?
It was a systematic review and meta-analysis.
Meaning they gathered up existing studies.
Exactly. They systematically searched the big databases Medline and Scopus to find relevant published research on this topic.
And what studies made the cut? What were the inclusion criteria?
They were looking for randomized controlled trials, or RCTs, and observational studies. The key was that these studies had to report baseline lipoprotein A levels in adult patients who'd already had an ischemic stroke, or TIA.
Okay. And importantly, they needed to compare outcomes in patients with high lipoprotein A versus those with low levels.
Makes sense.
Huh.
So what outcomes were they tracking? What was the main focus?
The primary outcome was stroke recurrence.
Any kind of stroke.
Well, the definition varied a bit between the included studies. Some looked at ischemic, some hemorrhagic, some any stroke, or even TIA. That's something to keep in mind.
Okay. And secondary outcomes.
They also looked at poor functional outcome, usually defined by the modified Rankin scale, dichotomized into good versus poor outcome.
So disability level.
Right. And they also examined all-cause mortality and recurrent vascular events more broadly, which could include heart attacks, for instance.
Got it. A comprehensive set of outcomes. How much data did they actually pull together?
They ended up including 12 studies in total.
12 studies.
Yeah, mostly observational, 11 of them were, plus one post-hoc analysis of an RCT.
And the patient numbers.
Pretty substantial. Pooling across those 12 studies gave them data on 17,903 patients.
Wow, over 17,000. That's a large cohort.
It is. Give the analysis some real weight.
What did that patient group look like on average? Any key characteristics?
The paper provides some pooled data. The mean age was around 63 years. About 38% were female.
Okay.
And the mean baseline lipoprotein A level across the studies was 34.4 milligrams per deciliter.
Useful context. Now, you mentioned mostly observational studies. What about study quality? Risk of bias?
An important point the authors addressed. The single RCT post hoc analysis was rated low risk of bias.
Good.
But the majority of the observational studies, most of the 11, were deemed to have a moderate risk of bias.
Moderate risk. Why was that?
The main culprits mentioned were things like unblinded outcome assessment. So the person checking for a stroke recurrence might have known the patient's lipoprotein A level.
Potential for observer bias.
Exactly. And also losses to follow up. Some potential selection and reporting bias were noted too in a few studies. Only 2 of the observational studies got a low risk rating across the board.
Okay, so that moderate bias risk is definitely something we need to remember when interpreting the results.
Absolutely. It's crucial context.
Right then, let's get to those results, the numbers. What did they find for the primary outcome stroke recurrence?
This is really a key finding for neurologists. They found that elevated lipoprotein A levels were indeed significantly associated with an increased risk of having another stroke.
Significantly associated. Can you give us the figures?
Yep. The pooled odds ratio was 1.69.
So about a 69% increase in odds.
That's right. 69% higher odds of recurrence for those with elevated lipoprotein A. The 95% confidence interval was 1.09 up to 2.63, and the p-value was 0.020. Statistically significant.
Okay, a clear association there. Did they do sensitivity analyses? Check if the result held up.
They did. They reran the analysis, excluding one study that used a slightly broader outcome definition. The association actually got stronger. The pooled odds ratio jumped to 2.28.
More than double the odds.
Correct. With a confidence interval of 1.23 to 4.21 and a p-value of 0.008. So that link to recurrence seems pretty robust in their data.
Interesting. The paper did mention high heterogeneity, though, didn't it?
It did. That's important, too. The I-squared values were high, 87% in the main analysis, 84% in the sensitivity one.
Which means there was a lot of variation between the individual study results.
Exactly. Could be differences in the patients, the lipoprotein A cutoffs used, how recurrence was defined exactly, lots of potential reasons. But the overall signal pointed in the same direction.
Okay, so higher lipoprotein A seems linked to recurrence. What about poor functional outcome, that secondary outcome?
They found a significant link there as well. High lipoprotein A was associated with increased odds of having a poor functional outcome after the initial event.
What were the numbers for that one?
Pooling 5 studies for this outcome, the odds ratio was 2.09.
Again, more than double the odds.
Yes. Confidence interval 1.40 to 3.11, and the p-value here was less than 0.01.
Highly significant. Was that confirmed in sensitivity analysis too?
It was. They did one excluding a study with a different modified Rankin scale cutoff. The association held firm. Odds ratio 1.96, confidence interval 1.29 to 2.97, p-value 0.0002.
Okay. Still high heterogeneity noted there too.
Yep, I-squared was around 77% and 79%, so similar variability story as with recurrence.
So we have links to both recurrence and worse functional recovery. What about the other outcomes? All-cause mortality.
Now, this is interesting. For all-cause mortality, they did not find a statistically significant association.
Oh, no link to dying from any cause.
Not a significant one in this analysis. The pooled odds ratio was 2.20, which sounds high.
But the confidence interval.
That's the key. It was wide, 0.89 to 5.43. Since it crosses 1, the result isn't statistically significant. The p-value was 0.088.
Right. So potentially a trend, but not reaching statistical significance in this data set.
Exactly. And what about recurrent vascular events overall, not just stroke?
A similar finding to mortality. No statistically significant association was found there either.
What was the data?
Pooled odds ratio was 2.66, again looking high, but the confidence interval was 0.95 to 7.44. Crosses 1 again.
So not significant.
Correct. P-value 0.063. And high heterogeneity here too, I-squared of 86%.
Okay, let's pause and synthesize that. The significant findings in this big meta-analysis seem quite specific. It's linking elevated lipoprotein A, particularly to stroke recurrence and poor functional outcome after stroke.
That's right.
Not so much to overall mortality or general recurrent vascular events. That specificity is quite striking.
It is. And the paper discusses why that might be. It goes back to those proposed mechanisms, the prothrombotic and atherogenic effects possibly having a stronger impact specifically within the cerebral circulation.
Makes sense.
And they also bring up the known association between high lipoprotein A and large artery atherosclerosis as a stroke subtype.
Which you mentioned is a common cause of stroke in their study population.
Yes, where they had subtype data, large artery atherosclerosis accounted for about 29% of cases. And we know that subtype carries a high risk of recurrence.
So The thinking is maybe lipoprotein A drives that specific high recurrence subtype.
That's one hypothesis discussed in the paper, yes. It could certainly contribute to the overall link with recurrence they observed.
What about the poor functional outcome link? Could it just be that higher lipoprotein A means a bigger, nastier initial stroke?
That's definitely a possibility the paper acknowledges. Some
Really?
studies have linked higher lipoprotein A to greater initial stroke severity.
Which would naturally lead to worse outcomes.
Of course. But interestingly, the paper also points out that in some of the included studies, the link between high lipoprotein A and poor outcome remained even after they statistically adjusted for baseline stroke severity.
Ah, so it might not just be about the initial hit size. There could be something more going on.
Possibly. It suggests the relationship might be more complex.
Okay, this leads us right to the crucial part for us clinicians, the practical implications. How do these findings square with current clinical guidelines on lipoprotein A?
Well, this is where it gets interesting. Current guidelines, like the ASEAS ones from 2019 or the NLA update from 2024, they do suggest measuring lipoprotein A in certain situations.
Like who?
Generally, people at high cardiovascular risk, maybe with a family history of early heart disease, or perhaps those having recurrent events even when their LDL cholesterol is well controlled.
Okay, so measurement is recommended sometimes.
Yes, but here's the gap. The guidelines don't yet offer clear, specific advice on how you should manage high lipoprotein A levels if you find them, specifically to prevent a second stroke.
So we might check the level, but then what? No standard playbook for secondary stroke prevention based on that number?
Not yet, based on the current major guidelines. And that's precisely why these meta-analysis findings are potentially so impactful.
How so?
By showing this significant link specifically to stroke recurrence and poor outcome, it really highlights lipoprotein A as a potential, maybe even probable, therapeutic target in secondary stroke prevention.
A target in addition to everything else we do.
Exactly. On top of managing blood pressure, lipids with statins, antithrombotics, etc., this could be another piece of the puzzle.
And the paper mentions there are drugs being developed specifically for this.
Yes, that's the exciting part. Novel therapies like antisense oligonucleotides or ASOs and small interfering RNAs, siRNAs, are in development.
And they work well.
Early trials suggest they can lower lipoprotein A levels quite dramatically. Reductions in the range of 80 to 90% have been reported.
Wow, 80–90%. That's huge. But we need to be careful, right? The paper stresses association isn't causation.
Absolutely critical point. This meta-analysis shows a strong link, but it doesn't prove that the high lipoprotein A causes the worst outcomes. It could still be a marker for something else.
Which means we need more research before changing practice based solely on lowering the number.
Precisely. The paper strongly emphasizes the need for large-scale randomized controlled trials. Trials specifically looking at these new lipoprotein A-lowering therapies in stroke survivors.
To see if actually bringing the level down improves those long-term outcomes, prevents recurrence, improves function.
That's the definitive evidence we still need.
Before we wrap, what did the authors see as the study's main strengths and weaknesses?
Strengths were mainly the comprehensive approach, pulling together all available studies, getting that large sample size of over 17,000 patients, which helps with generalizability.
Makes the findings more robust.
Yes. Limitations, as we discussed, centered on the fact that most included studies were observational, carrying that moderate risk of bias. Also, the significant heterogeneity we talked about, the variability between studies. And finally, the fact that not all analyses in the original studies could adjust for every single potential confounding factor, like all risk factors or acute treatments.
Okay, important caveats. So let's try to boil it down. The core takeaway from this deep dive into the source paper seems pretty clear.
Which is?
Elevated lipoprotein A levels are significantly associated with increased odds of both stroke recurrence and poor functional outcomes in patients who've already had an ischemic stroke or TIA.
That sums it up well. And the practical implication for you, the neurologist listening?
It's about recognizing lipoprotein A as a potential player in your patient's long-term risk after stroke, especially concerning recurrence and recovery.
And being aware of current guidelines recommending measurement in certain high-risk people.
Even though we don't yet have specific guidance on managing it just for secondary stroke prevention based on this level alone.
Exactly. It's an evolving area.
So here's a final thought for you to consider, stemming from this research and the drug development pipeline. With this evidence linking high lipoprotein A to recurrence, and with potent lowering therapies emerging, How might this influence your approach to risk stratifying and managing your stroke survivors in the near future? And maybe, how should we start talking to patients about this emerging risk factor?
A lot to think about there. And just one final reminder. This discussion was a summary for educational purposes.
Absolutely. Please do consult the full published paper, The Association of Lipoprotein A and Stroke Recurrence, a systematic review and meta-analysis in the Journal of Stroke 2025 for all the details and the full context.